nerve blocks, epidural injections, and radiofrequency ablation for the lower back pain. These are one of the interventions that we do at this time. And also we're going to talk about spinal cord stimulator. That's one of the advanced treatments for lower back pain. All right. Maybe some of you are familiar with WHO ladder that was developed first for cancer patients, but it's been modified for pain treatment as well. So the first step is the diagnosis, basically. That's what we actually look at. The first year is not actually invasive treatment, mostly behavioral cognitive behavior treatments, NSAIDs like anti-inflammatory medications, Tension is some of the treatments that are non-invasive. I'll talk to you guys about a little bit about that. Over-the-counter medications, rehab, physical therapy. The next year becomes systemic medications like opioids, neurolysis, thermal procedures, and nerve blocks. And the third tier is going to be the spinal cord stimulation, implanted drug pump, surgery, or neuroablation. So these are steps that we kind of try to catch during the study. Next slide, please. All right. So around 36% of Americans experience lower back pain in their life. So it's pretty common. Almost like 40% of people experience lower back pain. What are the signs of like significant underlying disease? So every time you have back pain, if it becomes chronic, always there is some underlying issue that is causing it. So it needs to be investigated and it needs to be worked out. It can be generated process. It can be this problem, or it might be a facet joint issue. So it might be a segmental problem in your spine. And also it might be sign of neurology. These are some of the things that we will talk about, some of the red flags that you have to be keep in your mind that if somebody, especially in older age, or they have history of cancer, they have to be cautious about. Common diagnoses are disc degeneration, facet joint arthritis that we will talk about in detail, disc herniation, that might cause nerve impingement and cause pain, lower back pain, and leg pain, and sacroiliac joint dysfunction. So we're going to go through all these diagnoses step by step. Next slide. All right. The first one is discogenic pain. Between our vertebrae, like a spine bone, there are cushions called discs, and usually these are aside the facet joints give the mobility to our spine. And the normal ones look like a hamburger, like on the top over here. And over time, our body gets older and everything, our joints, the whole body gets older and these discs get older, they lose their water, and they are not as flexible anymore. On the side, we don't know why, sometimes because of the trauma, and sometimes even without the trauma, these discs start getting bulged, they permeate outside. They might be a little bulged, or they might be completely herniated like this, or it might be even that herniated that kind of push on the spinal cord or the nerves and cause a pain. Sometimes they lose their height. They are not as good anymore. They shrink, they collapse, and that can become cause of pain as well. And sometimes, like arthritis in any other joints, in any other bones, we start getting osteophytes, which is the extra bone besides our normal bones. And those can cause pain by kind of rubbing on top of each other, and also they can push on the nerves too and cause pain. Next slide. So as I said, the discs can herniate. So if you look at over here, we have our spinal cord and our nerve roots that come out of the spine and they go to distal parts of the body to innervate the organs. So if they herniate like this, they can push on the spinal cord. A lot of times when the patient come and look at their MRIs, it's one of the imaging that you can see the pushing on the nerve or the impingement. Or it can go on the side and push on the nerve roots. So they can be lateralized. Somebody has, instead of having just back pain, they have a leg pain on the one side, right or the other side. So it means that they might have a nerve root impingement. Next slide. The other etiology that I talked about, the back pain, is facet joint arthritis. In our body, there are like a lot of joints. Between any bone, if you want to see the mobility, there is a joint in between them. And these joints are present in our back as well. So between the vertebral bones, these are joints that we call facet joints. Go alongside with the discs, they give mobility to our spine. So our flexion, extension, rotation to the sides, all of them are with these joints in the discs. Over time, when we get older, those get arthritis as well and can become really painful. And we will talk about how we can differentiate that, which ones are the reason. Not always easy to say that which one is the reason for your back pain, but we have some tools to put the right diagnosis and give you the right treatments. Next slide. The other reason for back pain is the sacroiliac joint. So this mostly is the buttock pain. So people, when they come and they have the buttock pain, they are not able to sit much. And when they are sitting, they have back pain. These are the ones that I'm always kind of suspicious that might be coming from your sacroiliac joint. This joint is between your sacrum and your hip. This is a real joint. And so all the real joints that have even the smallest mobility, they can get arthritis over time as well and can be painful. Next one. All right. So study was done to see that what is the common etiology for lower back pain in different ages. We talked about 3 different diagnoses already. One was the silent and bleeding one. The other one is the joint pain, the facet joint pain, and the third one is the discogenic pain. When somebody is younger, the probability of having a disc pain is really high. So if somebody comes with back pain, this is one of the most common diagnoses and the more prevalent reason for back pain. When people become older, because they start getting the arthritis, the reason for their back pain changes. So then you start getting the joint pain. So it's the facet joint pain becomes the more likely reason. And the side joint a little bit less. But they looked at 2 things. So the people who come, they have the back pain and only back pain, and the people who have the back pain and the leg pain, the thigh pain. So if people have the thigh pain, that's what it is. So most of the time in the younger age is the disc problem. Over time, when people get older, mostly the joint problem and less the sacroiliac joint. Next slide. On the other hand, they looked at the people who don't have the thigh pain. So people who don't have the thigh pain, they only have the back pain, and in the younger age, still the most likely reason for it is the disc. But when they get older, still the joint pain is the reason, the facet joint. But the likelihood of having the sacroiliac joint arthritis and the pain coming from that joint becomes really high if you don't have the thigh pain, and it's only the back pain or the bottom. All right, next one, please. So usually prevention is the best treatment. Not always possible, because when we get older, that's part of a natural course of our body to get the arthritis as we get older. But we can actually decrease the likelihood of it and maybe the severity of the problem when we get older. So the best way is exercise daily. Why? People come to my office and I tell them that, we are going to send you to physical therapy. And you say, oh, I go to physical therapy, I still have pain. The physical therapy is not to treat it, it's actually to help to improve and provide the muscle strength, core body muscle strength. So in any joint, if you have, and especially on your back, if you have a very good back muscle strength and even abdominal muscle strength, it will put on your physical activity less pressure on your spine. So less pressure on spine means that you use those joints a lot less, and you will kind of use them up less, and you will have less pain later and less arthritis. Good posture, lifting correctly instead of like bending over, you just kind of bend your knees and when you're lifting, so you will divide the energy on your spine a lot more equal. When you're bending, you're actually putting the force on a direct point. But when you are actually going like this, it means that the energy is going to, the force is going to be distributed through the whole spine and will be the less pressure and less stress. Proper sleeping and weight control. And I didn't put over here smoking. Smoking is one of the worst things for back pain, because every time we smoke, we get the heart problems, right? Our blood vessels get atherosclerosis, and they are tighter, they're narrower. Same thing happens in the same blood vessels in the back as well. They get less circulation, and they're more painful because they get ischemia. So smoking, if somebody has fracture, compression fracture of your spine, or any other sort of injury that needs to be treated surgically, or even non-surgically needs to be treated. In old people, even a small fall, when they are at home, that they don't even notice it, they don't think that it's significant, can cause serious problems because when you get older, you get osteoporosis, you get osteopenia, and it's very easier with the minor falls and minor incidents, we get major fractures. And the spine is one of them. Sometimes people even come to me and I look at their spine, I see that there's a fracture in their spine and they never even knew about it. They said that I had some back pain and it's just stayed there, and like when they come over here, we see that, oh, probably this is an old fracture, it happened maybe even like a year ago. So it's really important to watch those. Unexplained weight loss for any sort of cancer, especially if there isn't, because spine is one of the places that the cancers can metastasize. So if they're metastasized, then the bone can cause the back pain as well. So if somebody has an unexplained weight loss, be careful. Fever, chills, lymph nodes, for infection, people get infection, osteomyelitis means the infection of the bone of your spine as well, or any other bone. Issue of cancer, I talked. People who are immunosuppressed, people who use chronic steroids or medications that are like it suppress your immune system, and they have a hematological disease, or they are like a transplant patients that they have to be on chronic immunosuppression, they are more likely to get infections. And one of the places for infection can be the back, especially the bones. And if you have neurological symptoms or signs, these can be alarming. Somebody has losing their control of the bowel bladder. They have like a weakness. Pain is one reason, but if it really becomes the reason for your pain that you are actually getting weakness in your arms and your leg, you're not able to walk, and it happens, people get like a foot drops, or they like a drop in a glass of coffee or like cup of coffee. So it means that there is something serious going on and you immediately have to see a doctor. All right, next one, please. What are treatments? I always divide them in two portions, non-invasive treatments and invasive treatments. Non-invasive ones that I would say like a non-interventional starts with physical therapy and medications. Then becomes the minimally invasive and invasive ones that are interventional procedures that we talk about, and surgery will be the resource. Lastly, if there is no minimally invasive or non-surgical treatment, then you have to proceed surgery. Right. Physical therapy. So I'm not an expert in physical therapy, but I can give you guys like some hints about it. That exercise, they do this stabilization training, basically strengthening the core body musculature. Neutral positioning, soft tissue mobilization that's been done, especially if it's the myofascial pain, it means the muscle pain. And the transcutaneous electrical nerve stimulation is called TENS unit. These are patches that put on the back and they give vibration to the back. So we will talk about, there's a theory that is called gate theory, works based on that theory. So it basically distracts the body from sensing the pain. And they use it in physical therapy for actually giving this stimulation to the muscles as well. Next one. Medication. There are several medications out there available for pain and also for back. Back pain can be two types of pain. So we call it nociceptive pain and neuropathic pain. Nociceptive pain means that it's a mechanical pain. It means that somebody has something inflammatory process going on. That inflammatory process means that there's a mechanical issue. There's arthritis. There's something like maybe infection. But the neuropathic pain means that there is a nerve irritation or there is a nerve injury that's causing that pain. So some of these medications are good for neuropathic pain, and back pain can be both of them. Antidepressants. So most of the time when I start patients on antidepressants, and I was like, I'm going to put you under amitriptyline for your lower back pain, I said, I'm not depressed, doctor, so why are you putting me on antidepressant? I don't think that you are depressed. I think that it's been proven that medications like anticonvulsants, antidepressants, in a low dose, they are not good for depression, but they are very good for nerve pain. We call them nerve stabilizers. So if you have irritation of the nerve and they are charging, they are like firing too much, and when you are using medications like antidepressants or anticonvulsants, like gabapentin, Lyrica, these medications, they stabilize the membranes of the nerve so they don't fire too much and they don't hurt. Muscle relaxant, obviously, if it's the muscular issue or stiffness, it will count. Opioids can be used short term. Corticosteroids, are the medication options that you can use for lower back pain. So oral analgesics or any oral medications can be used, and we use them. Where somebody comes and they haven't done anything, and hopefully with just a simple physical therapy medications you can treat them. But if it becomes chronic and it's not well controlled, and on the other side, for long term, these medications, all of them come with side effects. And on the other hand, if you use interventions that you can control the pain with the interventions, they are low risk procedures. They have been a study done in Michigan. They looked at 380,000 blocks, liver blocks, around the anesthesia time. And the probability of having a nerve injury about 0.003%, very low. So these are very safe procedures. It's not zero. You know, everything I always tell my patients, even if we put an IV for you, there's a risk. If you're crossing the street from this side to the other side, you can get hit by a car. So that there is a risk, there is no risk, but it's a very safe procedure considering the benefits that you can get. What makes you high risk? People who are smokers. Because when you're a smoker, you are prone for all the complications, including infection and nerve injury as well. Diabetes. People who have diabetes, especially if they are on medications for diabetes, especially insulin, they are at a higher risk. And hypertension. So when they looked at that study, the people who had the complications, most of them had these risk factors. So this increases the probability of the side effects. Next one. What are the interventions? We're going to talk about different interventions that we can actually use to help with the back pain. Epidural steroid injection, facet, radiofrequency ablations, sacroiliac joint injection, spinal cord stimulation, and a particular drug delivery device that's, I'm not going to talk about it today, but that's kind of a last resource that mostly is used for end-stage cancer patients or people who have severe chronic back pain. Next one. Epidural injections. So epidural has been around for a very long time, and probably most of you are familiar with it, with the pregnant ladies, they use it for delivery. And certainly for back pain, it's been more than 40 years, and since 1980s has been used on the neck as well for the neck pain. And also, this is a pretty safe procedure, and every time that you do it, one of the common side effects of it is that we're going to talk about in the next slide, that there's a layer that you can place that you go in the epidural space, and you deliver the medication into that space. But if you are unintentionally a little bit deeper, there's like a line, and there's like a small thin membrane that if you pass, you get to the CSF, cerebral fluid. And you can get wet tap, what we call it, so you actually get a little bit of fluid. That increases the chance of having a headache after that. So people who get the complication, they might get a headache, usually goes away with only drinking coffee, water, anti-inflammatories, and it's done. But if it gets long term, then you can do a procedure. It's called blood patch. It's the same as the epidural. You give a little bit of your own blood and patches that wall, and it goes away. This probability is very low as well. It's 1 in 500 people get it. And in an experienced hands, it's a lot less than that. So what is that indicated for? It's indicated for nerve root irritation. It can be any back pain that mostly goes down to the legs, radiation. We call it radicular. It means that goes down to your legs, or radicular pain. And it can be for different reasons. It can be causing from the disc radiation, or it can be from anything that is chemically or mechanically irritating the nerves. So how does that work? So any herniated disc, degenerated disc, or annulosteroid means that if there is any tear in the disc, they start an inflammatory process. And this mechanical injury causes the release or leakage of phospholipase A2. Phospholipase A2 is actually in this cascade of inflammation, it's right here, and it causes arachidonic acid, makes arachidonic acid. And at the end of this cascade, it causes the production of leukotrienes, prostaglandins, and this general cascade that ends up in any inflammatory process. It becomes edema, it becomes inflammation, and irritates the nerve endings and causes the pain. So what we are trying to do with most of our treatments to block that process. Steroids, one of the medications that we can use our nerve blocks it right here. Some of the medications that we use in blocks in different ways, anti-inflammatory medications, block this place, it's cyclooxygenase. They block this enzyme, so they relieve the pain. Next one, please. So, as I said, one of the common medications that we use is steroids. And steroids block the synthesis of phospholipid B2, preventing the cascade of inflammation. On the other hand, also steroids block nociceptive input of the C fibers. C fibers are the nerve fibers that are very thin, and they are the pain fibers. They are the ones that send pain signals from the periphery to the spine, and from the spine to our brain to sense the pain. There are different types of steroids that we use: methylprednisolone, triamcinolone, dexamethasone. They are different in their potency and their lengths of effect. So, for back pain, as I said, most of the time, the safest place to put the medication that has the best effect on the low back pain that goes down to your legs is the epidural space. And what we are trying to do with most of these injections to access that space. That space is right here. Your skin, the soft tissue, the different ligaments, and then you pass this ligamentum pallavum. This is one of the places that you go with the needle, and if you're getting this procedure, and I'm doing it on somebody's back, we get a resistance. So it's like a firm, fiber, thick tissue. When you hit it, there's a resistance. And you push under the x-ray until you get a loss of resistance. You pass that space, and you already know that you are in the epidural space. That's how this procedure is done. The classic way of doing it is called interlaminar. Interlaminar means that you go in the middle. So these are the laminas. Like if you know a little bit of anatomy of spine, these are the laminas between the part of the vertebral bone, your spine bone. So interlaminar means that you go between two laminas. And we do under the x-ray, and we put steroid, and sometimes a little local anesthetic as well, not a medication there, to provide pain relief. There are 3 types of epidurals. I'm going to go through all of those. Interlaminar, the classic one that I talked to you guys about, the collar one, and transraminar technique. Next one, please. So, other than traditional interlaminar one, there is a other way of accessing the epidural space and give the medication for pain. Especially the people, somebody comes and they have a back pain that goes down to their both legs. It's hard to say that exactly it's one nerve root that is causing it, or different nerve roots are involved with that. I usually go with the traditional interlaminar one. However, if somebody comes and it's usually on one side, and I can actually, by physical exam or based on their imaging, MRI imaging, I can localize that there is a particular nerve root that is inflamed and it's involved in the reason for your pain. So instead of putting the medication, generally in that space, I can target that particular nerve root. This is the time that transforaminal epidural steroid injection comes handy. So what we do, so we use all these procedures under the x-ray. And on the side, when the nerve root comes out, we target that nerve root. And we deliver the medication. It has 2 advantages. When you are putting the medication on the back, so it's hard to get to the anterior part. It means that the front of that space. And if it's really on the side, it's really hard. But if you use this technique, there's a high probability that you can actually deliver the medication to that space and provide hopefully better pain relief. And also as well as more targeted treatment comparing to traditional epidural injection. And all these things are done under fluoroscopy, and we use a contrast dye, so we make sure that you are in the right spot and you check and make sure that it's not a blood vessel, and it's the correct spread, and then you give the medication. So this is a very, very controlled procedure. All of these are very controlled procedures. Next one. The other way of accessing that epidural space is the caudal. Caudal means that epidural space in our back spreads from our neck all the way down to the sacrum. And if somebody has a difficulty to get to their epidural space in their back, if they had a surgery before, if they had instrumentation in their back that makes it unsafe to put the needle in their back because that's normal anatomy is not there anymore. So then you can go, or they have a lot of arthritis that you can't even go through all those arthritis and osteophytes. The space is so small and it's impossible to go through their back. You can go from the bottom. It means that you can go through the sacrum and you can access that epidural space in this manner. The results are the same. You can even put a catheter if the pain is in the back with that space, and you go and deliver the medication where you want. Next one. The other reason for the back pain or even the neck pain is the facet joint arthritis. And these pains actually can radiate all over too. It's not like if you have the joint pain, it just stays in those joints. It can radiate if you're on your neck, it might radiate depending on which joints are involved. It can go even to the shoulders and even to the thighs if you have a lower back pain, buttocks area, or the groin area. So, and those are true synovial joints. It means that they have cartilage in the synovium. These nerves are innervated with two nerves. All of these joints are innervated with two nerves. One in the same level. It means that if you have two bones and there is a joint in between them, one nerve that comes from the same area of the nerve root, and one comes from the bottom, from the upper level. So if you want to help that joint to get a pain relief, you have to do two levels. The same level and the higher one, that both of them kind of give the ending nerves to that particular joint. What are the particular symptoms that you have a facet joint and it's not sciatica or the radicular pain? Most of the time, these are pains that don't go down to your legs. Most of the time, the pain is related to that you have stiffness, pain with prolonged sitting, standing, and pain goes to hip and buttock area. But not always it is as clear. So there are other ways that you have to find it, because a lot of people have both of the problems. So you might have arthritis on your back, and at the same time, you have nerve impingement that's causing the shooting pain. I usually, if I want to particularly find out, I would ask them if the pain goes below your knee. If the pain goes below the knee, there's less likely that it comes from the joints. And if it stays above the knee, it still can be from higher back that's shooting pain, but there's less likely that it's coming from nerve impingement. There's high likely that it comes from the joints. But there are other tests, physical tests, and like we use radiology, like MRIs and regular X-rays, and also we use some other procedures to actually find out what is the exact right reason for the back pain, and then we proceed with the treatment. Next one. So we talked about the facet joints. These facet joints that then become arthritic and they're painful, there are a few ways to treat them. One way to, like any other joint, somebody gets the arthritis in their knee, they inject their knee, they put steroids, and like that, they get a pain relief. You can do the same thing for these joints too. And it used to be actually quite often, they put it in the joint. But it can recur. But you cannot really replace these like a knee replacement or a shoulder replacement. So you have to do, or hip, like you have to do something else for it if they recur. So you don't have to like inject them more often. The better way is that the joint arthritis is not going to reverse. So none of us are going to go back to 20s anymore. But we can control the pain. What we can do, we can prevent the nerves to actually send the signals of pain to the spine and to the brain. So we can block the nerves that I was talking about at the same level, upper joint and upper level, and provide pain relief. Two ways of doing it. You can actually block those nerves, putting over a local anesthetic and steroids to bring the inflammation of the nerve down. And the other way is you can actually ablate that's the reason for your back. All right? So like you don't want to do a procedure that we are not completely sure about. So the way to get sure about it is to do a test procedure. So if I'm suspicious based on somebody's physical exam or somebody's MRI or X-ray results, then probably this is a facet joint arthritis. You do a medial branch block. The nerve that comes to the joint, we block it under X-ray, and we actually give only a non-medication to those nerves. And right after the procedure, usually we go and ask them how much of your pain is gone. If somebody tells me the same pain that I was experiencing before, more than 80% of that is gone, then it's a positive thing. But we do it twice. So we make sure that it's not a placebo effect. So they didn't get it just because they got a treatment, you just went to a doctor. A lot of us like feel like that, you go to a doctor and feel better. So we do it twice, and you do it, and if you have consistently tell me that both times more than 80% of the pain is gone, then I would be almost confident that this is the reason for somebody's back. Then you go with the actual treatment, which is nerve ablation or radio frequency ablation. And when you do the procedure, you put the needle right on this nerve over here. And this is the joint and this is the nerve that goes down there. But I have to make sure this is the right spot, all right? So to find out that it's the right spot, we have to test it. So there are two tests we do it. First, I want to make sure that I'm right on the target. So to make sure it's right on target, I do a stimulation. So we do put a probe in there, inside the needle, and we find out if somebody tells me that I'm feeling that stimulation less than 0.4 voltage, then I'm on the right spot. Then I do a motor test. I do stimulation to make sure that we are not putting the needle on the nerves that are actually giving you the mobility. So they are motor nerves. So if you pass both tests, it means that we are on the right target, and then we do the radio frequency ablation. Next one, please. So what we do, we give a heat of 60 to 100 degrees Celsius. What it does, it causes protein coagulation, causing irreversible damage to the cytosolic and mitochondrial enzymes. And so it interrupts the signal. This is a good treatment, very effective treatment, but our nature of body is the healing. So those nerves still grow back. So usually this keeps the pain relief for about 6 months to a year. So in some people, with their on the side of this pain relief, when they do the physical therapy, they get their core muscle strength back. So they might never get the back pain, but if it comes back after a year or 6 months, the same procedure can be done. You don't have to do the test anymore, so you just do the vertical. Next one. The other reason for back pain we talked about was the sacroiliac joint. So this can be caused by different reasons. So it can be because of the trauma, it can be the infection, gait alteration, people who have like a hip pain or they have like a surgery on their back so their back doesn't move anymore. So if you have putting the instrument on the back, so the normal distribution of the force that was on the back is not there anymore because some of them don't move. So if they don't move, it means that the pressure of the weight or your activity goes to the different joints. And one of the joints that takes that extra pressure will be the sacroiliac joint. A lot of these patients come back with their upper level of effusion, lower level of effusion, facet joint arthritis, or they come with the sacroiliac joint arthritis. And also tumors, or sometimes it's just the aging process can cause the rotation or position. So usually the pain is this upper medial part of the body. And tender on palpation. There are some physical exam findings that we do. They call it tantric test. I ask you to put your basically foot on the opposite side and you push it, and if your back hurts, it means that it's the same joint that's under pressure and it causes the same pain that you have. That's a positive sign that it might be, the reason might be this. Sometimes the injection itself, we do the same injection that we do for the epidural, but instead of putting the medication in the epidural space, we put it inside the joint. This is a lot simpler procedure than epidural, and we put a little bit of a steroid and non-medication there. Sometimes even 1 or 2 injections gives prolonged pain relief. But if it's temporary, there are other procedures that can be done. Same thing that we were talking about, the nerve ablation, radio frequency ablation, can be done for the same joint, nerves that come to that joint. So it can be done to provide longer pain. Next. So how much these are effective? And the question is like how much we are actually, there's evidence behind these that they are helpful. American Society of Interventional Pain Physicians looked at all the available literature for all the spinal interventions and ranked their level of evidence for them, the good, fair, and limited. The level of evidence is very good for caudal, for epidural and transforaminal injections, for radicular, or means that the pain that goes down to the left, it's the radiating pain. Its level of evidence for spondylosis means that the arthritis of the facet joints. RFA is, evidence for RFA is pretty good. And for neck pain, for radiating, shooting neck pain, the epidural is good evidence for it. The level of evidence is fair for back pain that is not radiating down to the legs. Sometimes it can be because of the facet arthritis, it can be because of the discs, so discogenic pain. So the level of evidence for it is fair. For SI joints, the evidence is limited, so there's not a lot of evidence behind it. But still, we see a lot of patients that actually with a very simple injection like this, they get a lot. Next one. One of the other treatments that are available for the people who don't get benefit from the simple procedures and they are not a good candidate for surgery, or they already had a surgery and they didn't get benefit from it. So it's spinal cord stimulation. Spinal cord stimulation is a new era treatment, but it's really not. It's been around and we knew this for a long time in old Greece. So doctors told people that if you have any pain, you can step on a torpedo fish and you wait until your leg gets numb and then you won't feel any pain. People went. I don't know how safe it is, but like you can do it, so you can try it. But they did, and they recommended it. So they knew the idea that you can use neurostimulation, that this neurostimulation might help with the pain. We use it for knee pain, and I think you use it for headache as well. So the idea was they would know what to do, how it works. Next one. So, but in 1965, two guys, Melzik and Wall, wrote an article, and they explained probably why it works. And they called it a gate theory. I try to simplify it. I always say when you are hitting something and your arm really hurts, one of the natural ways that we do for ourselves or somebody else that our loved ones comes like and rubs our hand. When it rubs our hand, we feel better. Why do we feel better? The reason is that in our spine, there is a gate available for the signals to go to the brain. And this gate is limited for the number of signals that it can send. And if you make that gate busy with non-painful signals, there will be a less available space for the painful signals to go back. And when you are running, you're making that gate busy. Same thing that neurostimulation does, makes that gate busy with non-painful stimulation, so the painful stimulation doesn't get a chance to go everywhere. So, and it's kind of like electricity. So like it's a different pulse electricity that causes the same effect. After 1965, it took about 2 years that Shirley and colleagues, they put the first spinal cord stimulation trial. And so that's the first early stimulation device in the 1960s. That's a Leyden jar that you can put a lot of static electricity in. And this is a modern generator for the spinal cord stimulation. Next one. So what is spinal cord stimulation? So basically, spinal cord stimulation is that it's when we are doing the epidural injection for somebody, is you put the same needle and you go to the same space, but instead of putting the medication, we put some catheters. So there are some electrodes that go in that space, and these pulse generator. That pulse generator sends the stimulation to the back of our spinal cord, which is called dorsal column. And that works with the same gate theory that I explained to help with the pain. This is a minimally invasive therapy, and it's reversible, and it's done like other procedure that I explained to you guys after a trial. So it means that somebody comes and gets the same things, but they're not implanted. They go home, try it for a few days, and if it's successful and they tell us that they actually had adequate pain relief with this, and then the second stage will be putting the generator under the skin, like I always call it, it's like a pacemaker. Pacemaker for the heart, and you can get a pacemaker for the back pain or other pains. So it's implanted under the skin, and constantly you can get a treatment for it. So this is the leads that I was talking about. This is the generator that goes in the body under the skin, and this is the controller that patient and the programmer can have to help with the program. So what are the components of it? There are two types of leads. So this procedure can be done in two ways. One way is percutaneous. It means that instead of having a surgery, you just put the needles, like the neural needles, and put the leads and hide it under the skin. The other way is that instead of putting it at the neural space, they have to actually do the surgery and put it closer to the spine. It's called cattle leads. That's a surgery. So that's like a full surgery that's been done, and usually it's done by neurosurgeons or other spine surgeons, like orthopedic spine surgeons. So, and they are usually more wider and flat and wide. These are the cattle leads, and these are the percutaneous leads are narrower, and it's done under the skin, under X-ray. And they have the pulse generator. As I said, the pulse generators are two types, external and internal, and they have a controller, and that you can actually program different plans of treatments for it. And usually they have like different plans, different type of treatments, like a pulse, and they can actually, they have various type of treatments for it that usually tried by the patient, see that which one like suits their pain, and which one actually gives them better pain relief, and they can give them more function. There are two types of it. Some of them actually old types and traditional types that we call it tone. So like you actually feel the paresthesia, called the vibration sensation. That's the sensation that actually prevents the pain going back there. And they are like new ones that we call it high frequency. The frequency of the stimulation is more than 10,000, and actually you don't even feel it. There are pros and cons for each one. There are like suitable for different ways, and it's more technical discussion. Next one. So as I said, it stimulates the dorsal column. How it works? So it inhibits the pain transmission going to the brain, and also increases the inhibitory pathway. So because when there are two types of pains that actually go in, stimulation goes up, and our brain actually sends back some of the inhibitory that inhibits the pain. So that comes usually with the modulation of the GABA factor. And it has some effects on the more than even higher than our spine. We don't know like exactly what, but even sometimes when you give them intermittent stimulation, and if you stop it, even if there's no stimulation, people still feel it. Next one. So what are the treatments that this treatment can be used for? It can be used for back pain, it can be used for leg pain, it can be for nerve pain, so like on the leg and cause neuropathic pain. It can be even used for ischemia. It can be used for peripheral vascular disease. Somebody has ischemia on their legs. It can be used for angina, for heart problems too. It can be used for failed back surgery syndrome, means that somebody had surgery, but the surgeon didn't help their pain. And it can be called for complex cerebral pain syndrome. Somebody had minor injury and they're struggling hurting because swelling, change of color in the legs, and it's not going to be improved by normal treatments. What's the evidence? So we're almost done. So the planned back surgery, there's a very good evidence for it that it kind of provides pain relief, functional capacity, helps with your quality of life, and the return to work is very favorable effect. Complex regional pain syndrome, favorable perceived effects, pain reduction, and this ischemia, somebody has ischemia in the leg, there's good evidence for it, and also even for angina. So it's not done very commonly in the United States, but in Europe they use it for somebody who has like a heart problem but they're not a candidate for surgery. And sometimes it actually provides a very good pain relief. They have like a fewer angina attacks, lower nitrate use, and improved exercise capacity. Okay. What are the contraindications? So if somebody has a psychological problem, so you are not suitable for having an external device, implanted device in your body, so we always send these patients to a psychologist to make sure that they are a suitable candidate for this. Somebody has uncontrolled bleeding if they are on anticoagulation or they have what means that they are not making clots very well, so they might not be suitable for this. And if somebody has an infection, systemic infection, or somebody has another implanted device, pacemaker, so they might contract their tumor, so we don't use that. If somebody relative contraindication is one of the ones that people have, like a really weak immune system and they are immunosuppression. Next one, please. So we talked about the different parts of it, the leads, the pulse generator, and the programmer that usually the clinician uses to keep the different programs. And there's a controller for the patient as well. Next one. And as I said, this can be done with a trial first, and if it's a successful treatment, then go for an implantation. Next one. And the level of the treatment is based on where the pain is. If somebody's pain is like a higher, the tip of those leads is put on the higher part of the spine. If it's lower on the leg, it goes down there. And you usually map it where you have to put the tip of those leads. Next one. So we talked about different things. We talked about the back pain, the reasons for back pain, that it can be coming from the disc, it can be from the nerve impingement, it can come from the cassette joints, it can come from the sacroiliac joint. The treatments are the epidurals, radio frequency ablation, and the sacroiliac joint injections, and the nerve injections, and the spinal cord stimulator, and you can right over that I talked to you, that it's more for cancer patients or more complex